Bear with us, guys. Did we get somebody there? Hello, Arno.
There was a picture I saw on the computer this morning of Dodger Stadium in LA, and it was totally surrounded. Didn't get into the stadium, but was all around the stadium. All the roads had it.
Nothing to absorb it. It's just up on a rock.
Yeah.
Right there.
The Zoom meeting is muting it.
They can hear you. You're not gonna get it. I can mute. Should I mute?
Would you raise your hand if you can hear me? Can you hear me? Bill said
Very
yes.
vague.
Dr. Ellis said yes.
Yeah, somebody raised their hand. Nobody raised it.
But we can't hear you. Okay.
Maybe you should shut down and restart your Zoom session.
How's everyone doing today?
Very well, thank you.
Thank you.
Well, thank you all for taking some time to let me come into your lives today.
Can you all hear me speaking from?
We appreciate having you here.
Can you guys hear us? Can you hear us, Bill?
Yeah, I think I started working with Man to Man back in 1996. It's been a while.
Can you guys hear us? Can you guys hear us?
No, I think so, because I got it done just like a couple weeks before.
When you hear it, you talk.
Can you guys hear us?
Faintly, I hear someone back there in the background asking.
Wave your hand if you can hear us. You can hear us a little bit or louder?
Yeah, you got, yeah.
A little bit. Okay.
A little bit.
Good. 1 second.
Can you all hear me okay in your room?
I can hear you.
Okay, good.
Okay. Don't want to know,
Does that help any?
That's a lot.
Yeah, that's true.
That good, guys? Is that better?
Yes, very much.
Okay. So if you can all hear me, raise your hand real quickly and then we can get started because I think we can hear you. I'm sorry about that. We have these occasional little technical issues that arise every now and then, but
I'm dragging Tony to fix them.
in any event, welcome aboard. We have a few guys here in the room. We have a few guys on Zoom. And Dr. Ellis has been kind enough to join us from Fort Myers to explain something new to all of us, I'm pretty sure. And I think it'll be a very interesting meeting. I want to, first of all, welcome Dr. Rod Ellis, who is, as I mentioned, with Genesiscare in Fort Myers. And he is the National Medical Director of MRLinac, which is something he will explain to us. One of relatively new radiation technologies, I believe I'm accurate in stating. And, it's very exciting news for all of us because we're always intrigued with what some of the options are for us to look forward. Now, many of us in this room are prior to treatment, maybe in watchful waiting or aggressive surveillance. Others of us have had treatment and are on the other end of that, trying to analyze what the next steps may be if we have recurrence. Some of us are having recurrence of one sort or another. So there'll be a bunch of questions, I'm sure, Dr. Ellis, about some of those issues and how MRLinac might apply to that. But without further ado, why don't I let you take it away? And again, thank you so much for doing this for us.
Great. Well, thank you all for taking the time to listen to me for your hour that you've got with me today. I don't know if this is going to give a little bit of a feedback loop. It sounds like there's a little bit of a feedback loop reading back in through the main room. Is that better now?
Yeah.
So as I said, I started working with men-to-men or man-to-man back in the day in 1996, back when prostate seed brachytherapy was fairly cool and new, and I've published extensively on brachytherapy for treating prostate cancer. Hold a number of lead roles for academics in radiation oncology. As I say, I worked in Cleveland at University Hospitals and Case Western for about 25 years as their vice chair for radiation oncology and directed GU radiation oncology for them. And then took the chair position at Penn State University prior to joining Genesiscare down here in Fort Myers. So I'm going to share my screen and just start running through some slides with you today, talking about another new technology, the medical linear accelerator with a MRIdian, an MRLinac. So here we go. Host displayed participant screen sharing. Are you able to enable me to screen share?
Oh, yes, I'm sorry. Let me,
Let me know when you're ready. I'll share my screen for everyone.
See where it says the green button on the bottom there?
okay, I just made you co-host.
Excellent. Let me see if this does the trick then. And I can open that screen up a little bit for you. How's that look?
Excellent.
Okay, great. So again, my name is Rodney Ellis. I'm the Genesiscare Fort Myers head for MRLinac, but the former inaugural chair for radiation oncology at Penn State University. I also hold a role as the co-chairman at the NCI for the renal task force and serve as a member for the NRG GU steering committee, which is the group that makes all the clinical trials that we do that are government funded for radiation oncology in the United States. So I'm going to talk a little bit about those trials today and about this new technology from ViewRay called a Meridian MRLinac. The Meridian is a machine that has both a linear accelerator, the machine that makes x-rays for treating prostate cancer, as well as an MRI married together. So they're both running at the same time and imaging the patient during treatment. So I'll show you videos of that, talk a little bit about some of the clinical trials, and then hopefully leave a little time for questions and answers at the end. But if anyone's looking for questions or answers from me afterwards, you can see down here in yellow a phone number to contact my office directly, and I'll bring that back up at the end.
Great.
Let's see if we can get to the first slide. Phil got me go forward. There we go. So prostate cancer, there's a number of different ways you can treat. As you mentioned, some people in the room are doing active surveillance or watchful waiting, depending on their aging. You know, younger men, we generally do active surveillance. Older men, if we don't think it's as life-threatening, you might say watchful waiting, wait to see if it progresses before you treat it. But once you cross into treatment, it generally is either a short course of treatment or a longer course of treatment, with the shorter courses being either surgery to remove the prostate, brachytherapy to put radiation into the prostate, or more recently, stereotactic body radiotherapy, where we're giving a large dose of radiation each day, Monday through Friday typically, or every other day over 2 weeks, to complete treatment in 5 fractions. Some of you may be familiar with the term CyberKnife, which is an older technology for doing this. But the MRLinac is a newer technology that's actually imaging up to 8 frames per second as we're treating the patient to give us real true time imaging during treatment. Longer courses of radiation are usually regarded as either proton therapy or external beam radiation, which takes 7 to 9 weeks to get through daily. Just some quick facts on prostate cancer. There's about 250,000, almost 300,000 patients annually every year in the United States diagnosed. Approximately 1 man every 2 minutes gets diagnosed with prostate cancer, and 1 in 8 will die from prostate cancer in their lifetime. Now, the good news is not all men are dying from prostate cancer, and there's over 3.1 million prostate cancer survivors today. When we do talk about treatment for prostate cancer, though, most of my entire medical career for the last 30 years, it's mostly been long courses of external beam radiation therapy, where you're treating, as the X's show here, Monday through Friday over a number of weeks, up to 9 weeks to complete the course of treatment, which is not only expensive, but inconvenient for patients. But we were able to prove over the years that by giving a little bit of radiation each day for a longer period of time, we were able to get cure rates that matched or exceed what you'd expect to see with surgery up front. And so that's been the standard for quite some time. When we talk about, go ahead, question?
Would you mind going back to that last page there? Because from what I heard you say, that it was, you said 1 in 8 men die from prostate cancer, but
Correct.
But it said 1 in 8 men were diagnosed with prostate cancer. I didn't know.
Oh, wait, sorry. Let me drop the screen down. I'm blocking part of my screen on my here.
Third,
Yeah, I see what you're saying. So yeah, again, although there's almost 35,000 men that will die from prostate cancer in 2023.
Yeah, I didn't get the
1 man dies from prostate cancer, they say every 15 minutes. But again, most men do not die from prostate cancer. Generally, it's a very treatable disease.
I'm sorry to interrupt you.
No, I'm glad I clarified that. Sorry. Again, most men nowadays, though, are not offered a short course of radiation. Only about 10% of patients that are treated with radiation nowadays get this short course of radiation treatment. And it's not because it's more expensive. It's actually one of the most affordable ways to treat. But in order to do it well, you've got to have the right team, and that includes the physicist and the radiation oncologist. And more importantly, the right equipment to be able to do this, giving a large dose each day and limiting the dose to just the prostate and the immediate surrounding tissue. And we're going to talk about that in depth today. Prostate cancer recurrence. They say that about 20 to 50% of men that are treated for prostate cancer have a recurrence. And now that may be either surgery and they recur after surgery, or have radiation and recur after radiation. If someone recurs after surgery, we often give them radiation in an effort to give them a second bite at the apple for cure. Or occasionally nowadays, we also see patients that have failed with radiation primarily that have radiation failures within the prostate gland. And we can often use new technologies such as a PSMA PET scan to see what area of the prostate has the recurrence, and use that as well to deliver 5 fractions of radiation as a second form of radiation for cure. What makes the ViewRay Meridian very different is really shown very clearly in this image. It's the same image from the same patient, but on the left is a CAT scan, and on the right is an MRI. And you can clearly see the detail of the anatomy much better on the MRI, so that you can segment or draw and identify each organ in the body, which is quite hard on a standard X-ray or a cone beam CT. So it allows you to see better with the Meridian. More importantly, it's very precise as well. We can see on an initial plan here for a pancreas cancer. Can you see my mouse, or my mouse showing up on your image there pointing at the cancer, or no?
Yeah. Yes. Yes.
In blue or purple right next to it is the stomach. And so they've done a plan in order to give a high dose of radiation to this pancreas to avoid the stomach. But then when the patient shows up on another day for his treatment, the stomach has moved slightly. It's now over here at the 3 o'clock position and is within the radiation field. One of the things that's very unique about the Meridian is it allows you to re-image and replan every day as needed. So when this patient came in and the stomach's now in the radiation field, we simply adapt the plan and change where the radiation's coming to spare the dose to that stomach and avoid the risk of having toxicity associated with the treatment. So we're shaping and treating delivery daily as needed for up to 5 times to treat patient in the course of their therapy. With conventional treatment for prostate cancer, we usually add a large margin around the prostate, because every day when you line up your
for
treatment,
prescriptions. So I'll do everything there.
I'm sorry?
I think it's just an interruption there.
Oh, that's okay. I just thought you had a question. So again, when we normally treat someone with prostate cancer and we line them up every day, we bring them into the room, we line up to marks on the surface of the body, We may take a cone beam CT to see it and line them up better. And then we say, hold still, we're going to do your treatment. But we're treating with our eyes closed. We're not watching during treatment. And anything can happen while that's taking place. So we have to make the field large enough so that if the prostate moves, it treats it. Fortunately, nowadays, we no longer need to do that. We could use the meridian and use a 3 millimeter margin in every direction and actually strike and treat just the area that we need to treat. I'm going to start this video and you'll be able to see this now. This shows internal pictures of the motion of the meridian. The angle is going to come in for treatment on each side. You're imaging over here to the right. You see the prostate expanding. The bladder is here. You can see it clearly. The prostate's in blue. The margin we're treating is in red. And it's only going to treat when that blue is inside the red. You can see it turning itself on and off as the patient's anatomy moved. And once it comes back in, the machine resumes and starts treating again. So again, it's turning itself automatically on and off anytime anything moves, allowing us to use a very pinpoint precision to treat just the tissue that needs treated. Again, as we watch over here, we see it move back in, the beam cuts on and off. If it moves out, it's going to turn off again. And that's really the biggest difference to this technology than anything that's ever been available to us before to treat men with prostate cancer. Now, from a patient's experience, they're here in the donut, the bore of the MRI, and we can put a pair of glasses on them so that they can see the screen behind them. So they can actually see what we're seeing on the monitor outside, and you'll see it's giving little feedback to them with little smiley faces when everything's lined up to the right spot. Now, this is someone with a prostate or a pancreas cancer, but we've got to get the pancreas into the target area before the machine will come on. And once it's on, it'll give smiley faces and let the patient know, okay, we're giving your treatment, but it's only treating when those faces are on. And it's cutting itself on and off. This allows us to do treatments even for pancreatic cancer, liver cancer, or lung cancers that have a lot of motion, in addition to prostate cancer. Now, typically with prostate cancer, it's not moving that much, and we don't necessarily need to make you hold your breath during treatment, but this is just showing a demonstration of what it's like for a patient when we treat them on the meridian. Now, what clinical evidence do we have on the meridian and for prostate cancer, in that matter, that says that we can treat in 5 fractions instead of 45 daily treatments over 9 weeks? Well, first off, there's been a number of different cancers treated on a meridian. Over 45 different types of disease have been treated on these machines since they came out in clinical use in 2017. Prostate cancer is one of the most common, and here's an early...
Ended by the amount of calls that I got to check in on it.
I'm sorry, David?
I'm not sure.
I'm not sure if David had a question or not.
Yeah, be there.
Oh, there's muted. So this trial, I actually wrote this trial. I'm the principal investigator for this trial, NRG GU005. This was opened up to treat intermediate risk prostate cancer and compare 5 fractions to standard treatment over 28 fractions. It was open in 6 different continents or 6 different countries, but mainly recruiting in the United States and Canada. We put 633 men on this trial. We'll get some results next year, some of the early results, but we're randomizing between standard treatment for either 28 or 20 treatments, depending on what that country typically uses their standard, or 5 fractions using a linear accelerator. We started this trial with 2 objectives. One was to show that there's fewer side effects by treating only 5 fractions with a small margin, and also to show that there's a 30% improvement in cure rate. We'll have data by next summer on the 5 fractions for the urinary side effects, and we'll have data by June of 2027 showing whether or not we achieved our goal of showing a 30% improvement in cure rate. If either or both of these endpoints are found to be positive, then this will by default become the standard of care for intermediate risk prostate cancer globally. There's also additional trials that are open right now that I'm getting ready to open here at Fort Myers that look at high-risk patients, Gleason 8, 9, and 10. And these trials are asking questions on whether or not we need more or less hormonal therapy. You know, many patients that have prostate cancer get hormones to block their testosterone, which is fairly debilitating and currently is often given for 2 to 3 years. There's newer tests such as Decipher that are looking at the genetics of your cancer to see whether you're a high or low risk. And these trials are randomizing to see whether you need more intense hormonal therapy, or with your favorable, whether they can back down a little bit on the amount of hormonal therapy they give. My point of showing these studies is these are the first studies that are being offered that do allow, as a standard of care, an option of doing treatment in 5 fractions, even for high-risk patients. And so my goal within the next 6 months is to open these trials down here in Fort Myers as well, so that any patient, Gleason 6 to Gleason 10, could be offered treatment and only 5 treatments, either on or off a clinical trial. GU10 does a similar stratification, again, for higher risk patients, but again, allows for treatment with 5 fractions, which is what my intent will be to do here. This also allows for what they call a micro boost, for used in advanced imaging and giving a little bit of higher dose of radiation in the area of the prostate that has cancer versus lower doses of radiation in the rest of the prostate gland. I just wanted to touch base on those trials just so people are aware of them and realize that you don't necessarily need 9 weeks of radiation anymore, but it's a standard of care to offer 5 treatments rather than 9 weeks for anyone with a Gleason 6 or anyone with a Gleason 7. But once you go to Gleason 8, 9, and 10, generally that's only currently being done on clinical trials. Another trial I'll point out, GU0011, is for men that have had prior treatment but show progression of the disease. And many of those guys are automatically put on hormonal therapy. This important trial is asking whether, if you've got 6 or less sites of metastatic disease, could you use just radiation, or do you need hormonal therapy in addition to radiation? So these patients would randomize and either get 5 fractions of radiation to the sites of the disease plus a placebo, or 5 fractions of radiation or a new oral type of hormonal therapy, Regulex, and they would get that for 6 months. Once we've completed this study, we'll unblind and see whether the radiation alone did as well as the radiation with hormonal therapy. If so, some of these men may in the future be treated with radiation alone without immediately having to start hormonal therapy until they show signs of further progression, or hopefully, potentially try and prevent it from progressing any further. I'm going to jump here to a different disease site. This is renal. This is an image from my friends at the University of Wisconsin, Madison, looking at kidney cancer. I've done a lot of work in kidney cancer. And in this patient had a kidney cancer at the top of the right kidney. You can see it lights up bright red or yellow here on a PET scan. This patient was treated, and here's an image after it was treated on a meridian. After the cancer has been treated, it's gone. And that was after 5 fractions of radiation. You can see the meridians, again, watching during treatment, turning itself on and off, and trying to make sure that the kidney doesn't move as the patient breathes, but is only going to treat when it's in the right location. So let's shift gears, though, and talk a little bit about this new machine, the Meridian. This was one of the very first trials that was published on the Meridian. This is a phase 2 trial of 101 men treated in Amsterdam, one of the first centers to get the Meridian. They treated over 100 men. Most of them were medium or high grade because they don't tend to treat much low grade prostate cancer in Europe. So about a third were medium, almost 60% were high grade. But we were able to show in that study that the urinary side effects, the bladder irritation, occurred in less than 24% of patients, and GI, rectal irritation, occurred in less for 5% of the patients. And that's within the first 90 days. That's basically the toxicity during treatment, which generally largely resolves after treatment. We're going to look at some additional data here in just a second, showing that here in the United States, a comparison trial was done looking at treatment on a standard linear accelerator versus an MRLinac. This is called the Mirage trial. This was from UCLA. This just published in January of this year, but they ended up treating 154 patients. Half of them got treated on the new machine, the MRLinac with Meridian. Half of them were treated on a cone beam guided machine, similar to what is available in most communities. What they were able to show on this trial at 90-day endpoint is there was a 60% reduction in the urinary side effects and elimination of any significant rectal toxicity. This was recently reproduced on a clinical trial in a study that was looking at published trials globally, and showed that Yes, in fact, on the Meridian, there's a 50% reduction in side effects compared to a standard linear accelerator when you're treating with 5 fractions. So again, 60% reduction in toxicity, no GI toxicity. The majority of the patients treated in this group were intermediate and high risk. One more experimental study they're doing is the Scimitar trial post-prostatectomy. Normally, if someone's had their prostate removed and they decide they need radiation afterwards, we still give about 34 to 35 treatments in most centers, each day, Monday through Friday. This trial was trying to compare the CT-guided treatment to the MR-guided treatment and doing it in 5 fractions, and showed a 30% reduction in any bladder toxicity and a 32% reduction in any GI toxicity. And how did they accomplish this? They're using much smaller fields. They're just treating the area where the prostate used to sit and now keeping most of the bladder out of the field. So they're only giving that high dose of radiation in this V-shaped area through here. I think this still needs a little bit more time to look at these data, but it's certainly very encouraging that maybe even in the post-prostatectomy setting, we could start trying to achieve a 5-fraction regimen for those men as well.
Wow.
One of the other things that has an advantage on this Meridian is it can image in multiple planes. So here's what they call a sagittal plane, where you kind of slicing the patient down through the middle. You see their tailbone, their head's up this way, the feet are down this way, but this is right through the middle. This is their belly. We slice them in a coronal image right across the shoulders and through their head, so their back's behind you and they're facing towards you. You see this image. Or here in a transaxial image, cutting through like a cereal loaf, you're right through the middle of the prostate. On this slide, what you're going to see as we treat is the Meridian's going to move. This is in fast time. It's moving quicker than the 10 minutes it takes to actually deliver the treatment. But as it's moving from site to site treating, you're going to start seeing the dose of radiation building up. You can see it imaging and showing you as it's treating and recording what dose it was giving as we build around in the circle to give the entire dose of radiation to the patient. So a very, very different technology than what has previously been available. So
Truly amazing developments.
It really is amazing. That's why I was really excited to speak to you guys today, because although when I put my first Meridian in at Penn State, it was only the 17th that was in the United States. Today, there's over 50 machines in the United States. But the one I installed here in Fort Myers was actually only the 26th that went in the United States. And there's not another one within a 2-hour drive of where I'm at. Now, where you're at in Sarasota, you could go over, to example, to Moffitt. They have one. But Moffitt has probably about a 2-month waiting list to get on the machine. There's so many patients with pancreas cancer, liver cancer, and lung cancers that are emergently needing treatment that most of the prostate cancer patients, unfortunately, are having to wait a couple of months to get in to be treated at Moffitt. Because I've only been down here about a year or so, and most people don't realize I'm on the Gulf Coast yet, I can usually get patients in to see me within the week and get them started within a couple of weeks. Let me get on to the next slide.
Excuse me, I had a question.
Sure.
If you could go back to that previous image. And so the question is, I know with some of the techniques that use, and even external beam radiation, I've been told, have issues on men that have bilateral hip replacements. How is this impacted or not impacted by having that type of procedure been done?
Sure. So first off, most men that have treatment on 5 fractions require an invasive procedure to put some little gold markers on their prostate they call fiducials. Because this is imaging in real time and able to see the prostate, it does not require any invasive procedure. You don't need fiducials. I used to run a proton center in Cleveland. And if you had 2 hips replaced, we couldn't treat you on protons. If you had 1 hip replaced, you would generally treat 1 angle above the proton or hip and then 1 angle through the hip. But protons, you usually only use 2 fields. Here, because we're treating from all these different angles where you see an arrow, it doesn't matter if you've had both hips replaced. And more importantly, on a standard linear accelerator with standard treatment, all the planning is done by a CT. And if you have 2 hips replaced, you can't even see the tissue here in the middle because it gets blocked out by artifact from both hips. On the Meridian, because it doesn't have that metal artifact, even if you have both hips replaced, I can very easily image and treat you. That's a great
Okay.
question.
Thank you.
Are there
David,
any
you have a
plans
question?
of bringing this machine to Sarasota?
Again, the right now there's only 200 of these types of machines available in the world.
Yeah.
Genesiscare put their very first machine in Australia. They were the first company to do so in the world. They've got 2 in Australia, 2 in the United Kingdom, 2 being installed now in Spain. This was to be the first here in the United States. Initially, I came down here with the intent that we were going to put about 25 of these in. Genesiscare is currently going through a restructuring. It's probably going to change names in the next month or two. And we'll have to wait and see whether whoever restructures and brings us forward puts in the rest of the machines. But I was very fortunate to get this machine up and running. I don't know how long it would be before one would be available in Sarasota, given that there is one at Moffett and there's one down here. There's actually 5 and a plans for a 6th machine to be installed in the state of Florida. There's 2 in Miami. There's 1 in Orlando, 1 in Tallahassee, and this is the 5th one here. There's one going in Palm Springs that would be the 6th unit if it comes up and running. But most states, the United States, are lucky to have 1 of them. So I don't know how quickly there'll be one placed in Sarasota.
Will Dr. Sylvester be staying with your group?
Yeah, he's still with Genesiscare, of course. Yeah, I know John very well. He and I were both very active in the prostate brachytherapy back in the days when he was still in Seattle. I've given my age away a little bit. Yeah, I worked with John for many years, academically. He joined Genesiscare a number of years ago. I've joined about 1.5 years ago. Again, I used to do prostate brachytherapy. I've got the highest cure rate published, along with Greg Merrick, for the intermediate risk men with prostate cancer with brachytherapy. But I have to be honest, although I've taught a lot of residents how to do prostate seed implants, I actually like this machine much better now because it's less invasive. You don't have to poke needles in the patients. You don't have to put a catheter in the patient. The urinary symptoms resolve much quicker. They only have to do 5 treatments. So even if you have to make a long drive to come down here, it's, an hour drive down and an hour back. That's 2 hours out of your day, but you're generally only coming in 2 days per week. I do it like Monday, Thursday, Monday, Thursday, Monday, and you're done.
Thank you.
Yeah. Yeah, that sounds like a piece of cake compared to 30 or 40 drives of a half hour each.
Right, exactly. It's a little bit further to make the drive to come down, but once you're plugged in and found to be an appropriate candidate, then you're fine. Now, let's speak about appropriate candidates. I've had a patient that has a pacemaker is not ideally an appropriate candidate unless they've got an MR compatible pacemaker. A patient with a defibrillator, I would not put in a magnet, and so they wouldn't be appropriate. But a patient with a defibrillator might be better served in active surveillance or watchful waiting if they've got a bad heart. But an MR compatible pacemaker, we have treated one patient already with an MR compatible pacemaker that we were able to turn it off during the treatment, then turn it back on for him before he went home. Other patients that are not good candidates, if you've got any metal objects in you that are metallic, would stick to a magnet, we can't put you in. Like if anyone ever shot you with a bullet and didn't take it out of you, most bullets have some iron in them, so you can't get in a magnet. But if you've had an MRI before or recently and not had anything done to you since that MRI was done, you're probably compatible to have them ready and done. But if you had, say, for example, maybe a cochlear implant in the ear or something that has a contraindication, we'd usually run through a screening and make sure before patients are imaged and treated that we've screened to make sure it's safe. And then, of course, check with their insurance company to say, yeah, that's in our, policy that we allow you to do MRLinac. MRLinac has no more charge than a regular linear accelerator, so there's no new charge for it. And it's actually a less expensive treatment than standard external beam or surgery. So most insurance carriers do not have a problem. They're actually excited by patients that are eligible to be treated on this machine. But some of them it's a new technology and they don't know about it yet. So sometimes you have to explain it to them.
Does your treatment require a specific protection for the bowels and rectal area?
Yeah, you're talking about the Space OAR Barrigel products.
Yeah.
The distance between the prostate and the rectum. So my clinical trial that I told you about earlier, I'm going to go up to that trial if I get to it again. When I did GU005, I wrote that trial specifically thinking about the toxicity and how to reduce it. And so we allowed the use of a space OAR in that trial. You can see here on this slide, we said rectal balloon, space OAR, or both. And we just said, do what you want. You could either do none of it, one of them, the other one, or both. As it turned out, about half the patients got a space OAR. So out of the 633 men, about 315 got SBRT, and half of them got a space OAR. So we will have some data coming out of that trial showing whether there was or was not a benefit of using a space OAR for these patients. There's a clinical trial that is open right now by the company that owns space OAR, Boston Scientific, called the SABRE trial. And they're looking at that question as well. So there'll be more data. I was actually one of the first people to use, actually was the very first person to use space OAR on a patient after it was FDA approved. And I'm a co-author on 6 of the papers that came out of the original study. There were 19 centers that we treated men on for the initial study. And so I've been working very closely with the companies and using that product for many of my patients. With the Meridian, because there's such a tight margin and it turns itself on and off, I'm not sure we'll see the advantage to it. It certainly can help to decrease the side effects. But in the original trial that got space OAR approved, there was only 4% significant toxicity in the patients that didn't have a space OAR, and only 1% toxicity in the patients that did. So if there's an advantage, you're only reducing it by about a 3% difference.
Yeah. Okay.
Those are great questions. Does anyone else have any other questions? I don't want to hog the attention from everyone and make you miss time to ask any critical thoughts.
Fascinating developments in the field for sure.
Well, this company grew out of Cleveland, Ohio. And so I was aware of them back in 2014 when I started writing this particular trial. And so it was the first trial that was written that was allowed to use an MRLinac. The other trials that I pointed out, 009, 010, and 011, all allow use of an MRLinac. I've also got a clinical trial that we're getting ready to open here. It's a very interesting trial to follow up on this trial called the Sugar trial. This is for men that are Gleason 7, 3+4, but they've done a decipher test and looked to see whether they're high risk or low risk. If they're high risk, they allow them to go on the trial and be treated with hormonal therapy plus 5 fractions of radiation, and it would allow me to use my MRLinac to do this. But the hormonal therapy in that case is that new medicine Regulex. It's an oral agent, and they take it only for 30 days, 15 days before the treatment and 15 days during treatment, and then you stop the hormonal therapy and you finished your treatment. So I think that'll be a very exciting study. It's a preliminary study. It's only going to treat 60 patients, but that's now been approved by the manufacturer of the agent. And so that's going to Pfizer. So they're going to be opening that up. Cornell University, Columbia University, Memorial Sloan Kettering University, Yale, and then my site will be the 5th site that will open that up. So I'm in with good company on that one. But we'll be the only one in the state of Florida offering that trial. So I just want to take a few minutes today just to introduce myself to you folks up in Sarasota and say, yeah, I know John, he does a great job. I know a lot of you have probably seen by John Sylvester. And again, if you're looking to do an implant, I'll defer those all up to John and let him do those all day. But I'm doing this all day. So if anyone's interested in this, it's available within Genesiscare. It's available within a short drive. We'd be happy to see any patients that are interested in doing it. I'm going to put up my last slide as we talk a little bit more as I flip through to the end, because I don't know if anyone had a chance to take notes on the first slide when I put the contact information. I wanted to at least leave that up as we get to the end. Should be getting there if I didn't go too quick.
So if we make your information available, it's okay for a patient to give you a call for a preliminary discussion?
Yep. If you call this phone number here that I've got up on the board, ask to be seen by me, they can make a self-referral and come down and see me on consult. I'll be happy to see anyone on consult.
Okay.
Doctor, I have a question.
Sure.
You see many radiation treatments without the use of hormonal therapy?
Oh, I do a lot of patients without hormonal therapy. I only use hormonal therapy in the patients that need it. Anyone who's a Gleason 6, you don't need a hormonal therapy. Anyone who's a Gleason 7, 3+4 may or may not benefit from hormonal therapy. I'm a co-author on the trials that we just looked at. That 0815 was the original trial that looked at that question and said, can we identify the group that don't need hormonal therapy? As it turned out, that was a negative trial. We couldn't identify the group that don't. But what we do know is there's a lot of men that we give hormonal therapy, but only a limited number that actually needed it. So there's new developments that are out now, whether it's the Decipher test saying you've got a high risk, maybe you should consider hormonal therapy, the Prolaris test that says maybe you should consider hormonal therapy, or there's a very exciting new one called the Artera that just got published just last week in the New England Journal of Medicine, where it takes a picture of your slide. It takes the original slide, has an image, a color image made, and it uses a computer analysis to do artificial intelligence reading of the slide to look for architectural features that identify it for high risk. We use that in 3 different RTOG trials that we had long-term data on and trained the computer to identify the differences for high and low risk men because we knew the outcomes of the ones that died and the ones that didn't die. After we trained it on 3 series of patients' data, we let it run on a 4th trial to predict which patients would do well or not do well on its own. And it validated that it had learned from the first 3 and correctly predicted on the 4th trial which patients were at high risk. So we're now saying that that could be potentially used for patients that maybe have an indication for hormonal therapy but aren't sure if they want to do it, to test to see whether they should or shouldn't do it and make a decision. Do I want to do hormones? And if I do, how long do I want to be on the hormonal therapy? We're trying to reduce some of the side effects with hormonal therapy. It's going to take years and trials to get the data to prove it and make it a standard of care. But I'm certainly going to be proactive in helping men be on those trials or to help men make decisions that don't want to be on trials on how they'd like to direct their care.
Well, in a study like that, doctor, do they look like pre-existing slides that you've had, biopsy slides that you've had like over the course of, if you had more than one biopsy slide? Is that the comparison you're looking at with the AI?
They'd probably just take the most recent highest grade ones, because if they looked at the older ones and they're lower grade, it wouldn't, that wouldn't trump the newer one that said it was higher grade. So they'd probably take your highest grade. Well, now, if you, for example, had a Gleason 7, 3+4 and did active surveillance, and you're out 2 years and you get another biopsy, it comes back a Gleason 6, then yeah, you might want to look at the Gleason 7 slide. But I'd probably look at the slide that had the biopsy proven highest risk and use that to make the determination whether you should or shouldn't consider hormonal therapy. Because a biopsy is only as good as the piece of tissue that came out of the prostate. It's like drawing needles out of a haystack and asking what's in the haystack. Unless you take the prostate out and serial section through the whole prostate, you don't really know what's in there. Nowadays, we do a better job with MR imaging and PET scan imaging to do directed biopsies and try and get a piece of tissue that truly represents the cancer. But, in the days of yore, they used to just stick needles in the left and right and see what they got. And if it was negative, it's negative. If it was positive, it's positive. Now we're getting better imaging, better information. But no, I wouldn't use an old slide from 4 years ago. I'd probably use your most recent slide. And they generally recommend that you have a slide that's done within 6 months of starting treatment to help drive your decision on how aggressive to offer therapy.
Well, it just seems interesting that, that AI would be able to pick up different features that maybe a scanner or an individual who's been viewing very many of these, looks for patterns, sees things that are familiar, makes a rating on it, makes a Gleason judgment on it. Whereas with the AI, they may be picking up different features that even the experienced eye is used to, but not necessarily noting any difference. That's why I was wondering if more than one slide would be able to see where the differences lie.
Yeah, I'm sure they will probably do even more studies with that further. As I say, this is one of the first papers that came out validating. I've ordered it on 10 of my patients. They let me get 10 patients for free. I'm now available to order it for any patient that wants to have done. As long as their insurance will pay for it, we're happy to get that information for them. But if I sent 2 separate slides from 2 different biopsies, the insurance company would have to pay for both of those. And we just have to make sure the insurance company would say they would. And if I was the insurance company, I'd probably say, no, I only want to pay for one of them. So while it may be instrumental to build more data, that would probably have to be done on a clinical trial to look at multiple slides from the same patient. someone would have to cover the cost on that as part of the clinical trial.
Right. It just seems like a different set of eyes would be, you know, I mean, now that AI is getting so precise at the analysis that it would be, to give it more data, makes it more, you know, precise.
Well, like I said, we had data on patients that were in series of, you know, up to 1,000 patients on each trial. And so we used the first 3 group of patients to train the AI and the 4th set of data to validate the AI. So it's been done on thousands of slides. So the AI is pretty good now, and we're only going to get better, hopefully, as we continue using it. So that'll be probably embedded into some of the future trials, like the ones I showed today. You know, the future studies that come out will probably start embedding some of that data in it as well, I suspect.
I have a couple of quick questions that I may have missed your comment on earlier, but does insurance generally cover MRLinac?
Yeah, the MRLinac, there's no additional billing code because of the MR. It's just a more expensive machine. It was just the right thing to do to buy it and put it in. But the insurance companies we don't charge them extra for the MRLinac. It's just the standard treatment codes that we normally use. So it's usually not an issue on whether or not you can get treated on this machine versus that machine. And the fact that the side effects are 50% lower on this machine, again, most insurance companies, if they had the choice, would tell you have to be treated on MRLinac, because if you have side effects, we're going to have to pay for those too, and we don't want to have to pay more than we have to.
Right. If they have a choice, as you say.
Yeah, the problem is there's just not enough machines available, and that's why I felt it was important today to take time out of my clinic schedule to block my schedule and speak to you guys today to help reach out to the public and let them know this. You know, I gave a talk last month for the 50 vets in 50 states for the veterans, letting them know, because the VA has now started investing their money in MR linear accelerators as well. And so they want to make sure the vets are aware of it, or the vets that don't want to go to the VA or can't get to their VA because it's too far away or doesn't have an MRLinac can go to a site that has one, and the VA will now pay for them to do that.
Yeah. We've been getting very positive responses about VA treatment in general over the last couple of years. I don't know if that's your experience, but
they've become, I used to work in the VA in Cleveland years ago, which is a really good VA system, but there's only so much the VA can and can't do, and it can't move closer to where the vets are at if they're not living near the VA. So it was very good when a couple of years ago, they changed it and said the veterans have a choice. They don't have to be treated at the VA. They're welcome to be treated at the VA, but the VA would pay for their care if they needed to go elsewhere to do it.
Yeah. And you did say that Gleason 7, 8, and 9 can be treated with?
Potentially you could. Again, in these high-grade trials, they're allowing me to do that. And so on a clinical trial, I'd feel very comfortable doing it. I do have one patient coming to me now from Sarasota that had several cores that were Gleason 7 and one core they call Gleason 8. And I'm treating him off clinical trial with 5 fractions. So there are patients I think I could treat that are Gleason 8 with 5 fraction. But again, when you follow the NCCN guidelines, some insurance carriers may say, nope, you're Gleason 8, we don't do SBRT. Need hormones and external beam. But again, in those patients, if I can open up these other trials, then they would probably let me offer them 5 fractions because they're on a clinical trial.
Okay, great, thank you.
So yeah, I just want the getting the word out there that any patient on the Gulf Coast, anywhere from the Panhandle on down to Marco Island, is more than welcome to meet me midway down here in the middle of the Gulf, and we're able to do 5 fraction radiation for any men with prostate cancer.
Well, we've certainly had people travel to Jacksonville for proton therapy.
Oh yeah, no, when I was treating with my proton center, the furthest I saw a patient from come to see me in proton came to me from Vietnam, because he had fought in the war in Vietnam and then met a girl and stayed there. And then his son lived outside of Cleveland. So he flew back from Vietnam to Cleveland, stayed with his son, and went back and forth to do the 28 fractions of radiation that I offered him. But now I've seen patients already come in and see me from New York, from Indianapolis. They're starting to come from across the country because there's not that many of these linear accelerators available that have the MR. And so, I'm just making sure people are aware that we are one that's able to do it. It's very convenient if you live outside of the state of Florida to fly into Fort Myers, or even use a Legion Air to fly into Punta Gorda, and we're conveniently between those two airports. So I'm happy to see patients nationwide that are looking for this technology. And I've got the experience as a national investigator working with the NCI for years to say we've got the best equipment and best site available, I think, within the United States to do this.
That's
Certainly
great.
the best.
Well, this has certainly been very informative for all of us, and I think we've got some good voices to spread the word a little bit too about it, because we all have friends that are affected by this crazy disease. And
as I say, any of them that are interested, they can look us up. Again, right now we're called Genesiscare. Whether that'll be true come the first of the year, that might change. But that phone number that's up there is not going to change, and my name's not going to change. So you can Google track me down. I can run, but I can't hide.
Just
thank you very much, Doctor. It was really
thank you all very much for your time.
very, very helpful and useful. Any last minute questions before we close off?
I have one, yes.
Yeah,
From what my understanding is, your treatment is strictly for the prostate. It is not for if it has migrated outside.
So the high grade trial does allow the 5 fractions to also include the lymph nodes. It treats the lymph nodes in the pelvis if desired. 5 gray times 5 is delivered to the lymph nodes. 7.25 times 5 is delivered to the planning volume.
Okay.
And then in the prostate, when you see a dominant lesion, you can go up to a higher dose and give a micro boost. And so I'm routinely integrating that into all patients. Usually I'm not treating patients with lymph nodes on that machine yet. I would only want to do that on the clinical trial.
I see.
If I open those trials and patients say, yeah, I want to do the 5 fraction, I'd certainly be happy to do it on that machine.
Only for the lymph node if necessary.
Yeah, only if necessary for the lymph nodes. Generally, we're using PSMA PET scan imaging now to help us see whether we truly do or don't have to treat the lymph nodes.
Okay.
If PSMA PET is positive, then I'd say yes. Generally, most of those patients, I'll recommend 28 fractions of radiation. But if someone was coming from a long distance and we needed to figure out a way for them to be best treated, we could have that discussion.
No, I had radiation on the prostate, but apparently they found in the couple of years afterwards, nothing in the prostate, but it has migrated microscopic to a couple of lymph nodes in the pelvic.
Yeah. And I do treat a lot of those patients with 5 fractions. If they've got isolated lesions in the lymph nodes or a bony metastasis anywhere in the body and it's limited number, we certainly treat that. And like I said, on that 011 trial, Prometheus trial, they call it, that's up to 6 sites, and you can treat up to all 6 of those with 5 fractions of radiation, plus or minus giving them 6 months of hormonal therapy. And so that's an active area of investigation, and it's certainly something that patients may want to seek, even if it's off trial.
Okay. Thank you so much for your explanation and clarifying the question. So perhaps if I need, I will give you a call.
You're welcome to stop down and chat with me anytime. I see a hand up over there with Bob.
Yes.
Bob Johnson, a question. Bob, go ahead.
Yeah, Dr. Ellis, just a clarification in terms of what you said. If you've already had a prostatectomy and have a recurrence, and you're already on the hormone therapy and now have the radiation scheduled, my Gleason score was also high at a 9. Is that anything that could still be considered, or am I kind of beyond that?
The general recommendation, especially when you say it's a Gleason 9, and are they worried about lymph nodes involved? Did you have a PSMA PET scan? Did it show nodal involvement?
I had the PSMA PET scan about in May.
Did it have any cancer outside of the prostate bed or just the prostate bed?
Yeah, it's outside.
So in that case, usually, again, I would do either 25 treatments to the whole pelvis and reduce field boost to the prostate for 14 more fractions, or for some patients I've treated, I'll give a lower dose to the lymph nodes and a higher dose to the prostate bed and do it at about 26 fractions based on a prior study that's been published. So they are looking at that and saying, can you do it in fewer fractions? And could you use a meridian to do that? You absolutely could. The question is, most meridians, once they get up and running for a period of time, get flooded out with a number of patients waiting to get on board and be treated. And so most are then relegated down to just doing 5 fractions. Right now, since ours is not maxed out, if I saw a patient that was interested in doing 20 or 28 treatments, potentially we could do that.
Okay, thank you.
You're welcome.
Well, guys, I think we've exhausted Dr. Ellis. Thank you, Dr. Ellis.
Well, I appreciate
Thank
your
you,
time
Dr.
again. And if there are any other questions, again, don't hesitate to call that number,
Okay,
239.
Thank you, Doc. Thank you, Doctor.
Okay.
Thank you.
Yeah,
Awesome. You guys have a great day. Again, thank you for your time.
yeah, thank you.
All right,
Thank you, guys. Have a great evening.
You too.
thank you.
Thanks, David.